Assalamu alaikum, Masa al khair, good evening, and thank you for participating and attending our second webinar. Actually, the number of participants really indicates that pharmacists are passionate to educate themselves. I would like to thank Oman Pharmaceutical Society for this opportunity and for their tremendous effort in updating pharmacists regarding coronavirus management, either through educational videos or online presentations. Please feel free to ask any questions by pressing the question and answer buttons and typing it up. And of course, the speaker will be able to answer your questions at the end of the presentation. As you know, that the management is really not standard for all groups of patients. That's why we need to cover its management in different groups. So today we are focusing on pediatric, and guess what? Who's better than Zahraa to cover or present such topic? As Zahraa, she's a pediatric clinical pharmacist. She's working in Royal Hospital. She obtained her master's degree from Australia in 2010 from Australia, from Queensland University. And she has been working as a pediatric clinical pharmacist, and she's involved in neonatal areas as well. So in addition to her pharmaceutical care services, she is involved in managing improving projects in pediatric and neonatal areas. Welcome, Pharmacist Zahraa.
Assalamu alaikum and good evening, everyone. Thank you, Jannat, for the introduction. I would also like to take this opportunity to thank the Pharmaceutical Society for organizing this event and giving me this opportunity to talk about COVID in pediatrics. And I really hope that by the end of this presentation that somehow this will add value to your services. So as we all know, at the end of 2019, a novel coronavirus was identified as the cause of a cluster of pneumonia cases in Wuhan in China. It rapidly spread, resulting in an epidemic throughout China. And this was followed by an increased number of cases in other countries throughout the world. In March 2020, the WHO declared this as a pandemic disease. So just before I start, I just want to let you know that much of the information discussed today will be out of date, probably within hours or 2 days. So it's very important that we keep ourselves up to date, and I've listed a couple of web pages that are very useful, and they continually update their information on this COVID virus. So coronavirus is, they're important human and animal pathogens, and they're named as the spikes look like a crown. There have been 4 endemic human coronaviruses identified, and they're found worldwide. And they're responsible for the common cold, and they can be more severe in neonates. They do not induce durable immunity, so people can get infected. So people can get infected with each of the 4 viruses across the periods of their lives, and they are seasonal in winter and early spring. So there are 3 emerging coronaviruses. Bats are known to be a natural reservoir for the virus, and novel species arise from a combination of the bat virus with another host mammal. With SARS, it was thought that the virus jumped from bats to civet cats to humans. With the MERS, it was thought that the virus jumped from bats to camels to humans, and with the coronavirus, there are some reports to say that it probably jumped from the bats to pangolins, which is this animal over here, to humans, but it's not confirmed yet. In terms of transmissibility, most of the data we have are from China, and the incubation period is between 2 to 14 days, although some reports say that the incubation period can last up to 24 days. The basic reproductive number So basically this means how contagious is this virus, and the R naught represents how many secondary cases are infected on average by each person who is infected. And for the coronavirus or SARS-CoV, it's estimated that the R naught value is around 2.5. So basically this means that the average number of people that one person with a virus infects based on the R naught scale. So if we have one person infected with the virus, then we would expect an average of another 2 to 2.5 people to be infected. And if we compare this to other viruses, such as the Ebola virus, we can see that the SARS coronavirus is far more transmissible compared to the Ebola virus. And at the end of this chart, we can see the measles, which has an R naught value of 12 to 18. So I think we're lucky that we actually have a vaccine for the measles, because it transmits at a much faster rate compared to the SARS-CoV-2 virus. So if we talk about vertical transmission during pregnancy, can the SARS-CoV-2 be acquired in utero? Well, maternal-infant vertical transmission is doubtful. There is still no solid evidence documented of intrauterine vertical transmission occurring with SARS or MERS. And the management of neonates born to mothers with suspected or confirmed COVID-19 actually represent a special at-risk group and is beyond the scope of this presentation. We'll have to talk about that separately. In terms of infants and breastfeeding, it's unknown if SARS-CoV-2 can be transmitted through breast milk. There was a report that tested to see if the virus was found in maternal milk for 6 patients, and it was found that there was no maternal milk. No signs of the virus in the milk. Droplet transmission could occur through close contact during breastfeeding, or actually bottle feeding. It doesn't matter. And mothers with confirmed COVID-19 or symptomatic mothers with suspected COVID-19 should take precautions to prevent transmission to the infant during feeding. So we need to think about if a mother is infected or if a baby is infected, we need to think about, will we give the infant express breast milk or will we move to bottle feeding? And whatever method we decide to choose, we need to think about how we minimize the contact between the mother and the baby. And of course, that will take us to the emotional aspect of all of this. And this will require a lot of emotional support for both the mother and the infant and the nursing infant. At this time, there are limited data on the full spectrum of COVID-19 in children, and information on this topic is evolving. However, if we look at some of the data currently emerging, so in terms of the burden of the virus in children, as of 2nd of April, among the around 150,000 cases, lab-confirmed cases reported in the US, only 1.7% were in children below 18 years. And if we look at this chart, which describes the severity of symptoms in children, the severity of symptoms in pediatrics, this was a case series from China, which had about 2,000 plus children with lab confirmed COVID. And it showed that the majority of the patients actually had mild or asymptomatic symptoms. A few of them progressed to have moderate, so about 40%. And then very low percentage of them had severe or critical symptoms as the virus progressed. So there are actually risks of having severe disease. And those patients that progress to having severe or critical presentation of the virus usually have some sort of underlying condition that make them at risk of having severe disease. It could be an underlying lung disease, or they could be diabetic. It could be that they have chronic kidney disease, neurological and neurodevelopmental conditions such as cerebral palsy or epilepsy. Maybe they have congenital heart conditions and other chronic conditions such as sickle cell disease, or it could be that they're actually immunosuppressed. So why does COVID-19 appear to be less common and severe in children? It's still unclear up to this point. And some attribute it to a less vigorous immune response to the virus in children compared to adults. And the cytokine storm is thought to be important in the pathogenesis of severe COVID-19 infection. Another explanation is that viral interference in the respiratory tract of young children leads to a lower viral load in children, although there are reports that showed high viral loads in children that were infected with SARS-CoV-2. The receptor for SARS-CoV-2 virus is the angiotensin-converting enzyme 2 receptors, and this may be expressed differently in the respiratory tract of children compared to the adult population. So amongst those confirmed cases, there was a case series of about 1,400 children that were evaluated for COVID-19 at Wuhan Children's Hospital. And patients that presented to the hospital mainly presented with fever and cough. There were a few asymptomatic patients as well. Some also had a sore throat, and an unknown percentage also had GI symptoms. Also, in terms of presentation of symptoms, some patients presented with one symptom, other patients presented with maybe 2 or 3 symptoms. But it's important to understand how we monitor children for early signs, especially those young infants that cannot communicate easily with us. So we need to look for early signs such as irritability or low food intake, which will allow us to seek attention from medical care at an earlier stage, especially in younger infants who are not able to communicate what or how they feel. Also, be mindful of those patients that are asymptomatic, because these will be a challenge on how we can handle them. So if we move on to talk about the therapeutic options, we have the antiviral medications, which is the most commonly ones talked about are remdesivir and Kaletra. We have repurposed drugs. So these are drugs that are approved for a specific indication or a condition, but are now being used for a new therapeutic purpose, which is, in the case of SARS-CoV-2, the 2 repurposed drugs are hydroxychloroquine and chloroquine. And then we have the supporting agents such as azithromycin and tocilizumab and other medications that can be used in the course of the disease. So this slide is just showing us the general stages of the disease and the treatment modalities, just in general. You can see that the COVID infection can be classified into 3 main stages. So it could be the asymptomatic or the mild stage of the disease. And then it progresses to being more moderate stage 2. And it can further progress so that it becomes more severe. And you'll notice that in stage 1 and 2, it's mainly the viral response phase. And as the disease progresses and becomes more and more severe, we can see that the host response takes over and we get a hyperinflammatory phase and a cytokine storm. And based on the stages of the disease, this guides us to the potential therapy that we can use. So chloroquine, hydroxychloroquine, remdesivir, azithromycin, and Kaletra, in many of the guidelines, you will see them being recommended across the course of the infection. However, other medications such as interleukin-2 inhibitors, such as tocilizumab, or convalescent plasma transfusions or corticosteroids are usually not indicated unless the patient's disease progresses into a more severe stage. So most of the experience currently generated on the treatment regimens are from the previous SARS and MERS outbreaks. And again, these are mainly extrapolated from adult data. This is a table that is based on the Canadian interim guidelines. So I just summarized what the guideline was saying. And as we can see that the severity of the disease will actually guide you to the treatment recommendations. And we can see that most of the treatment recommended are not direct antiviral therapies apart from remdesivir. So most of them are those repurposed drugs such as hydroxychloroquine and chloroquine. And the other therapeutic options suggested such as supportive treatment just depends on the severity of the disease. So tocilizumab mainly has a role in the critical stage of the disease. So patients that move on to the critical stage have shown clinical features consistent with a cytokine release syndrome with elevated interleukin-6 levels. And they have shown characteristics of a wide array of life-threatening conditions and ineffective immunity characterized by an uncontrolled hyperinflammatory response, hence the role of the interleukin antagonist. The use of tocilizumab has been described in some reports. However, the outcomes have been more or less inconclusive so far, and the drug is being evaluated in clinical trials. So you'll notice that most of the interim guidelines will have, especially in the pediatric guidelines, will have a statement to indicate that the use of routine of experimental therapy is not recommended actually. And currently we are in a desperate situation. So we are trying them out to see what happens. However, even as we try them out, we need to appreciate the toxicities that are associated with those medications. The most common one, which I'm sure most of you know about, is the QTc interval prolongation. And what happens if we add azithromycin to the combination of hydroxychloroquine or chloroquine, because that also adds to the additive effect of the QTc prolongation. So we don't know the additive risks if those medications are used together. Other drugs that can be prescribed during the course of treatment, such as, for example, ondansetron, which also can increase the QTc prolongation. So if we have a patient that presents with nausea and vomiting, and it has been stated that children can present with GI symptoms, and on admission is prescribed ondansetron, then we need to be mindful of the fact that this medication can also exaggerate the effects of the QTc intervals if it's co-prescribed with hydroxychloroquine or chloroquine and azithromycin. We also need to understand that some patients can also present as to have hypomagnesemia, which is also a further contributing factor to QTc prolongation. Hypoglycemia has also been identified as an adverse drug reaction to hydroxychloroquine. And it does that by enhancing the insulin sensitivity, and it enhances insulin release. So if we have patients that are diabetics, we need to be careful with that and just be mindful of that it could be part of their insulin treatment, or is it an ADR that's coming from the medications that we're prescribing to treat the infection, the SARS-CoV-2 infection. Some reports have actually stated that they've had patients that have experienced the hypoglycemia, and they've actually had to consider octreotide to manage the symptoms of hypoglycemia. CNS effects also can manifest from the use of those medications. Also, we need to look for interactions, especially those medications that are metabolized via the CYP2D6 enzymes, such as tramadol, which is probably a medication you might see in the intensive care setting. Of course, G6PD is another thing that we need to be aware of. And retinopathy, however, if if the medication is going to be prescribed in the short run, then that's not something maybe we would worry about, because retinopathy is usually associated if you use those medications on long term. So really the inclination is, as you can see from this chart, is to start therapy not if a patient is in the first stage of their disease. So if they're mild and they have no risk factors for severe disease, then it would be advised to just have supportive care. However, if they're mild disease, and they have risk factors for severe disease present, so if they have an underlying condition, or if they're immunosuppressed, then you're more likely to maybe consider initiating treatment, bearing in mind all the things and the points that we just discussed. And we also need to remember that hydroxychloroquine is used for patients that have, for example, juvenile rheumatoid arthritis or SLE. And if we are going to kind of like stockpile all those medications and reserve them only for COVID patients, then we're going to affect those patients that actually need those treatment long term. So we need to have a balance and really understand what we're doing, be mindful of what we're doing. And when we initiate treatment, we're very careful at initiating treatment for the pediatric population. In the adult population, some might consider prophylactic medications. However, this is not encouraged in pediatrics. And you can see also from this chart, even where it's more inclined that you don't want to start treatment when they show symptoms of mild disease. You only want to start it later on, unless if they have a risk factor for developing severe disease. So really, before initiating treatment, we need to consider the exposure of the pediatric population to the disease compared to the adult population. And the CDC has mentioned that the exposure was about 1.7%. And COVID-19 is expressed differently in children, and fewer cases develop to critical stage of the disease. So we need to assess the risk to develop severe disease or critical disease. So look at the risk factors of the patient before we initiate treatment. And then experimental and compassionate use of medications. So compassionate use is it basically means that we're using an investigational therapy outside of a clinical trial, out of desperate measures. So how much exposure of these medications are considered to be safe in this population? And also we need to consider the formulations that we have for this population. So usually you will notice that the guidelines for pediatrics for the SARS-CoV-2 infection in pediatrics will not encourage to use medications at the initial stage of the disease. And you will find statements such as routine therapy is not recommended. Generally, this is because of these principles. It's to do with the fact that there are no randomized controlled trials evidence on which to base recommendations for treatment. Experimental treatments for patients with COVID-19 ideally should occur within the context of controlled clinical trials. And experimental therapies for compassionate use should only be considered on a case-by-case basis under expert guidance. And we also need to understand, do we have in our organizations, do we have a process to regulate this in our organization? So if we want to use medications for compassionate use, what are the steps and what's the system behind all of this? So if we look at the national guidelines that were developed, this is the Pediatric Therapeutics section. So how can we use this guideline? I think, or I would suggest that it's more of a monograph at this stage for quick access to dosing information if we decide on using a particular medication. So if we decide to use, for example, hydroxychloroquine, then we have the dosing there and we have some of the important notes. But it doesn't really give us, it doesn't really encourage us in terms of what medication to use in terms of the severity of the disease. What about those patients that move on to have severe or they move on to the last stage of the disease, where the host inflammatory markers are prominent, and that's the main response. So what about that part? I feel that that part maybe is something that we should consider when we're looking at those guidelines. So your role as a pharmacist, really, what we can do at this stage is within our organizations, we can possibly look at the evidence that we have so far, and maybe we can develop internal monographs that will help us during, for example, if a patient is admitted, and if the treating team decide to choose a particular medication, then it's more of a guidance on how you would use it. We decided at the Royal Hospital to add maybe a little bit more information, more than the dosing, more information on the administration of medication, especially IV azithromycin, because it has special instructions. We also included some monitoring on the special medications, renal adjustments, what formulations we have available, and any important remarks that we thought is important. We also added oseltamivir. However, it's important to note that in terms of evidence, it actually shows not much of benefit unless if a patient comes in with an element of influenza. So the current data in terms of guidelines and protocols, they're not necessarily designed based on an individual patient's physiology or a disease pathophysiology, in this case, SARS-CoV-2. Instead, they are designed really to help us to treat the majority or the mean of the patients who will present with an illness. And in COVID-19 patients who may quickly develop to critical condition, we don't just want to apply protocols blindly. And we don't want to assume as well that a failure to respond is the result of the patient. Instead, when our protocol if our protocol methodologies has failed, we need to step back and ask if we are using the wrong strategy for this patient's condition. So what do we know or don't know? At this time, really, there are limited data on the full spectrum of COVID-19 in children, and information on this topic is rapidly evolving. We don't know if asymptomatic patients are contagious and how long are they contagious for. Initial reports show fewer pediatric cases compared to adults, but we don't know if this is related to the child's physiology and how they respond to this virus. Or is it related to the exposure, the fact that they're exposed less frequently, especially with all the population measures directed towards social distancing, including the school closures? And these all appear to be important factors in slowing down the spread of COVID-19 in children. We need to warrant really close monitoring rather than an assumption of a mild disease course in individual pediatric patients. So what's next? I'm not sure if we know, but the current situation is very dynamic and information is being changed and updated regularly. It is very important to keep up to date with the evidence-based approaches that are available in the treatment of the virus, and any guidelines developed will be interim guidelines, and we will need to continually update them as more and more data emerge. So thank you very much. And just stay home, stay safe, and back to you, Jannat.
Thank you, Zahraa, for this really wonderful, informative, and well-prepared presentation. You give us really a good insight and management of COVID-19 and this special group of patients. And before we start answering our questions. I really would like to appreciate all pharmacists and their outstanding contributions to combat COVID-19. And actually, we have more than 160 participants and one businessman. So thank you for attending our webinar. And before we start answering the questions, also I would like to thank all the people behind the scene from Oman Pharmaceutical Society who really worked hard to make this event successful. Oman Pharmaceutical Society also will continue organizing such events and will keep you posted with the latest update in the society social media platform, which I advise you to follow. Since we have limited time, only a few questions will be answered by Zahraa. So Zahraa, when you are ready, please go ahead and you can answer the questions.
Thank you, Jannat. I can see a lot of questions here. I'll try to do my best to answer as much as I can. So how far is hydroxychloroquine safe in children? Hydroxychloroquine is used in pediatrics. It's used for other conditions, such as rheumatoid arthritis or SLE. It is considered safe to some extent as long as they're being managed and supervised and the adverse effects are being monitored. However, it's the fact that we don't have enough data in terms of its use in COVID-19 that we're more speculating about. There's another question about the medications. I have recently read that the COVID can lead to blood clots in the respiratory tract. Yes, there has been a lot of information emerging in that. We still didn't have, to be honest, we still didn't have a lot of patients admitted. We had one pediatric patient, and I don't think his case was as severe. I don't know about information on blood clots in children. Most of the information that I have read was based on adults. Does the time for starting of hydroxychloroquine early or late change the outcome? That's quite an interesting question, because although we talked about in pediatrics, we talked about how we have to be very vigilant and take it on a case-by-case scenario on when to start treatment. You don't want to just start it if patients are presenting with mild symptoms and otherwise healthy, but you would consider them if the patients are if the patients have mild symptoms, but they're at risk of severe condition, then yes, it does state that you want to start the medications earlier rather than late, but also be mindful about all the other adverse effects that it may cause. What is the main difference between adult and pediatrics treatment? Well, all the data from the pediatrics is actually extrapolated from the adult data. Did we try remdesivir in the pediatric cases in Royal? Unfortunately, remdesivir is not available in the Royal Hospital. How to use hydroxychloroquine in children? Do you have syrup? That's a very good question, which I think we have the answer to. We can dissolve the tablets, it's soluble. I think there is an extemporaneous preparation that we can prepare. So yeah, there's like lots of questions. I'm sorry, I can't maybe answer them all, but we will try our best to see if we can get back to you. Thank you. Go back to Jannat.
So I think this is the end of our webinar. Thank you very much for participating, and thank you, Zahraa, again. Stay safe, everyone, and see you soon.